Arshim?
Yes, sir. Good evening.
Good evening, good evening. Good evening, Ganesh Bhai.
Good evening, sir.
Good evening. So, who is answering today?
So today we have Dr. Ankit, Dr. Samit, Dr. Jeena as the volunteers, and Dr. Brijesh will be there. Sir.
Okay. Dr. Jinal has not joined.
चालू करना है क्या?
Just waiting just 5 minutes and then we'll
Okay.
start. Acha, I talked to Zubair Kazi, but he was not available. So that MRI ka we'll have to keep
Next
it.
time करेंगे.
Next time रख देंगे. We'll keep it next time. And Amandeep said that he is going to join sooner or later. So whenever he joins, we will start his class, like
तब तक अपन ये चालू रखते थे.
हाँ तब तक ये चालू रखेंगे. Just 2-3 minutes and then we will start. Let's see.
Yes, sir.
Dr. Gite and others, once they join. So today I joined JJ
अरे
again.
congratulations sir. आपका तीसरी बार है, चौथी बार एडमिशन हो गया.
Yeah. Dr. Gite is not yet joined.
रुकते हैं ना सर कुछ
So today I think we have got two. One is a locally advanced, and second is a metastatic. We will be covering two cases. So first we are taking it just locally advanced. I think during that time Amandeep will join. Let him talk, and then we will go for metastatic also. Correct, Ganesh?
सर बराबर
Good evening, Gaurang bhai. I'm here already.
हाँ, इसलिए मैं आपको एक ही रिंग मारता हूँ. आपको एक रिंग इज इनफ फॉर यू.
गुड इवनिंग सर, मैं भी ज्वाइन कर दिया हूँ ऑलरेडी.
इसलिए मैं आपको भी एक ही रिंग. So Pankaj and Gite ji, I went today and joined JJ.
Good sir, welcome back again.
I just heard it. Wonderful.
And I talked to the dean. So he said that he will talk to the concerned person. He wants to bring you here, na? Gite ko bhi.
हाँ सर, ऑलरेडी वो ऑन टेबल है सर.
Yeah,
एकेडमिक प्रोफेसर का.
correct.
तो वहाँ पे टीचर नहीं है, तो टीचर के लिए तो उनको लाना ही पड़ेगा. दूसरा ऑप्शन उनके पास नहीं है कुछ भी.
Right.
और मैं अगर गया तो पंकज सर को भी वापस लेके आएंगे.
Yes, we have to do something. No, definitely.
क्योंकि गणेश सर तो आएंगे नहीं बुलाए तो भी. तो वो बहुत बिजी रहते हैं.
गणेश तो आ जाएगा.
रहते हैं ऐसे कुछ नहीं.
Right. I think then we start now.
Yes sir, yes.
Yeah. Okay. So today 4 people are there. Jinal has joined. Dr. Jinal, na?
Not joined.
Dr. Jina. Okay. Anyway, she is not there. But Ankit is there, Samit is there, and Brijesh is there. Fine. And so today again I'm telling you we have got two cases. First is the locally advanced and second is a metastatic. Okay, Gina has joined. So in that Amandeep is going to join in between. So once he joins, he will be talking about the management of I think metastatic CA prostate, and then we will take the second case there. Okay, Harshit, start.
We're presenting a case of a 75-year-old male who had complaints of increased frequency of micturition since 6 months, urgency for 4 months, nocturia for 3 months, burning micturition for 3 months, and associated with loss of weight and
Yeah, fine. So Gina, this is a history. What comes in your mind, and then how you will proceed?
नहीं है सर, I think हाँ है.
Yeah. Who is that? Gina? Can you hear me? Brijesh?
She is already joining, but cannot be.
Okay.
listening your voice.
No problem. Brijesh,
Yes, sir.
can you just tell us now how will you go?
Sir, 75-year-old male with history of increased frequencies in 6 months, urgency and nocturia, lower urinary tract symptoms, with the burning micturition and weight loss and appetite, sir. So I would like to elaborate the lower urinary tract symptoms, storage symptoms, and voiding symptoms, and any history of weight loss. How the weight loss was there, sir? Whether it was gradual or it was sudden weight loss over 2 to 3 months, sir. Then what was any
देखने बोलो
history of any associated symptoms, sir? After I would like to evaluate IPSS score with the quality of life symptoms and any bothersome symptoms were there or not. Is there any history of previous instrumentation, catheterization, any history of hematuria, sir? Any other history of admissions in the hospital, any constitutional symptoms, any history of bony pain, back pain, lower limb edema, sir? And history of any radiation or history of any blood thinners or any other constitutional symptoms, sir?
Okay.
So, Brijesh, listening to his history, did anything draw your attention? What kind of LUTs does he have?
Sir, he has storage LUTs, sir.
That is what you have to say, that he has predominantly storage LUTs.
Yes.
Okay. Ganesh bhai, anything else? You think so?
Nice, sir.
Okay,
I mean,
fine.
This goes
Yeah.
on as a normal case presentation.
Yeah. Harshiv, go ahead.
The patient was relatively asymptomatic 6 months ago, after which he complained of increased frequency, which was initially 2 to 3 hourly, which progressed to every half hourly. Urgency, he first noticed 4 months ago, which has progressed to nearly urge incontinence. Nocturia, which was initially 1 to 2 times per night, has increased to 4 to 5 times per night over the past 3 months. Burning micturition has been persistent and associated with every void throughout the stream. There was a significant unintentional weight loss, about 12 kgs in last 6 months, noticed by loosening of clothes, and loss of appetite in last 6 months, wherein the meal intake got reduced to less than half of the previous. IPSS score was 12 out of 35, with frequency, urgency, and nocturia being the features. Quality of life index 4 out of 6, and patient is sexually inactive.
Okay, go ahead.
There is no history of hematuria, lithuria, dysuria, pyuria, fever, abdominal pain, nausea, vomiting, urinary retention, hesitancy, jaundice, puffiness, exertional breathlessness, lower limb edema, backache, bony pain, any bleeding disorders, blood transfusion, anticoagulation therapy, radiation or chemotherapy. Patient has undergone TURP 10 years ago, which was uneventful, and the biopsy report had come out to be benign at that time. Sleep is disturbed, bowel habits are normal, and bladder is altered as described. Patient is a non-smoker, non-drinker, and non-tobacco chewer.
Okay, so Gina, this is a history. You want to ask any particular thing?
Sir, can I have the first slide, please? Sorry,
Yeah.
sir.
Harshiv, first, yeah.
This frequency of obstruction, urgency, saturation, burning, saturation. No, sir. 75-year male presented with mostly storage, voiding nuts, and burning micturition for 3 months. Loss of appetite and weight are the most significant history he's been having for the past 6 months. And yes, sir.
Only 3 positive history: loss of weight, loss of appetite, and some past history of TURP.
So anything you want to know about after TURP, how he was doing, whether he had any problem in passing urine in last 10 years?
Where is the symptom post prostate surgery? Whether he had any episodes of retention post-operatively, or whether he had to undergo any other surgeries like dilatation in the past. So
Yeah.
that will be a significant history.
Right. Okay. So now next, what you want to do?
Sir, I would like to examine him, sir. So now the history is over. I would like to examine.
Okay.
IPSS 12.
On general examination, the patient has normal vitals. BMI is 21 kg per meter square. No palar icterus, cyanosis, clubbing, lymphadenopathy, edema, head to toe. General examination also does not show any abnormality. On the positive findings on per abdominal examination is patient has bilateral inguinal region cuff impulse. Otherwise, on palpation as well, there is no significant finding. Per rectal examination, there is grade 2 asymmetrical left lobe enlargement with hard consistency, irregular surface, non-tender and median sulcus being obliterated. Rectal mucosa is mobile and no blood or mucus on the examining finger.
So now, Ankit,
Yes, sir.
now what you want to do?
I would like
Now, what is now after this examination is over? What is your clinical impression?
a 75-year-old male predominantly with the storage lets and with significant loss of weight with history of QRP 10 years ago. Now had on examination grade 2 asymmetrical enlargement with the nodularity over the prostate. So my initial diagnosis will go towards the uh, malignant cause. So I would like to evaluate him on the malignancy cause.
No, so this patient, what is your that he is the post ERP, but still he has got a now enlarged prostate, correct?
Prostate, yes, sir. So
Now it
initially at the time of TURP, not the whole of the the very transition zone was removed and
no, so
the
at present he has got an enlarged prostate.
yes, sir.
Probably it is malignant in nature, correct?
Yes,
And
yes, sir.
and patient has got mainly storage problems,
Storage, yes,
symptoms,
yes, yes,
and
sir.
along with that he has got
But loss of weight,
yeah,
burning maturation.
yeah.
Yes, sir. So basically, he might be having urinary tract infection along with the body bladder outlet obstruction right now.
Fine. So now what you want to do?
I would like to go with the routine blood investigation like CBC, RFT, Euroflowmeter, and a bladder diary, along with ultrasound whole abdomen and pelvis with Euroflow and PVR with the urine routine.
Serum PS.
And serum PSA also.
Okay. Jina, you want to add anything?
No, sir.
Okay.
Urine culture, I can
Sir, urine
test
culture.
for
Okay.
he's
I
having
will do.
burning
I will do the culture
culture.
based upon the urine routine examination findings, sir.
Okay. Harshit, show them. What is the normal value in this serum creatinine?
It is around 1.5. In our lab, it's 1.5 around.
No. Some people have got up to 0.9. Some laboratories says 1.1. Some laboratories says 1. Like SciFi is having 1.3. So if it is in SciFi, it is within normal limit.
Yes.
Sir, this report was done from outside and the normal upper limit was 1.1, sir.
1.1. So patient has got
Right.
Mildly elevated.
Elevated creatinine.
yeah. So next, whatever they ask, just show them. Next. This is uroflowmetry. Yeah, this is ultrasonography. Anyone wants to try?
The left kidney seems to be normal with normal corticomedullary differentiation with normal cortical echoes. The right kidney also seems to be normal with normal corticomedullary differentiation and normal cortical echoes. The liver and the spleen seems to be normal. I won't be able to comment on urinary bladder since the bladder is not fully distended, sir. And I can't be commenting upon the thickness of the bladder wall, sir. And pancreas seems to be normal, sir.
Prostate. Great.
Because the
It has to
bladder is not fully distended, so commenting on the prostate will give me false results, sir.
But here you are able to see very nicely, na?
Yes, sir.
Then if you can't say that, if you are able to see it properly, you have to comment on that. You can't say that because the bladder is not full, I cannot comment on that.
Okay, sir.
So, Ankit, what is the impact of bladder fullness on prostate?
Intravascular prostatic protrusion, we can appreciate really well if the bladder is fully distended, sir.
I didn't understand. Come again.
Sir, intravascular prostatic protrusion, sir.
Mm-hmm.
So if the bladder is full, then we can appreciate the intravascular protrusion.
So, for optimum assessment of IPP, how much bladder fullness do you need?
Around 200 to 250 ml, sir.
So, my question was, what would be the impact of bladder fullness on prostate size?
Not much, sir.
Then you only mentioned that the bladder is not full, so you can't make a comment. Means, what were you trying to say?
So Ankit, once you see something very clearly, na, don't make any comment. You can say that bladder is not full, so you may not be able to talk about your bladder wall thickness and other things.
Whatever you are telling in exam, if you are not able to defend that, please don't talk.
So,
Think over it before talking. Think over it.
and especially if you are making some comment on the investigation provided, means indirectly what you said was this was a suboptimally done sonography. So if you make such a bold statement, you should be able to substantiate what you are saying. And just to explain you the impact of bladder volume on prostate, when the bladder is overfilled, the prostate would appear smaller, and in a inadequately filled bladder, you will not be able to analyze the prostate size. So to have an optimum assessment of prostate size, they said the bladder fullness should be around 150 to 300 ml. If it is more than 400, 450 ml, then the prostate size will get underestimated. Chale, आगे बढ़े. And I would further feel that at least the image of the right kidney that is shown, this kidney looks to me small with poor parenchyma. I don't know what the report is.
On reporting, their right kidney is smaller in size with bright ecotexture and 7 mm calculus in the upper region. Prostate is 60.4 grams and TURP defect is observed. Otherwise, it is normal. But the bladder is suboptimal because it is partially distended.
Okay, so what next?
So then I would explain the patient about the findings. And as the PSA is the elevated range of 34.3, and the DRE findings were suspected to be DRE findings is a hard irregular surface nodular prostate. So after that, sir, after explaining the patient, I would like to go ahead with a multiparametric MRI of prostate.
Why do you want the MPMRI?
So for the local staging, sir.
Would just a MRI pelvis not help you? Why do you need multiparametric?
So for the PIRAT scoring.
Are you really interested in PIRAT scoring? How is it going to help you?
Sir, if there are nodules are seen, so we want to target if any other abnormal nodule is there. So MRI would help to increase the sensitivity and specificity of the nodule along with the local stagings.
No, Dr. Maheshwari is asking you that is it necessary? You can just do a plain MRI, because you are not going to take a biopsy if it is showing period 3 or period 2.
For
No, I will still
standardized,
take a biopsy, sir, because my DRE findings are suspected to be a malignant. So I will still take a biopsy. So this MRI would just help me to target the lesion and to take additional course from that particular area if it is seen, sir. Then.
So would a MRI of prostate not give you those lesions for targeted biopsy?
So for PIRADS 3 and PIRADS 4, we would require a dynamic contrast enhancement. So to differentiate between that, we require MPMRIs.
Good. So basically, this MRI is not being done to decide whether we need a biopsy or not. The decision of biopsy is already made. MRI would help you in local staging and also help you decide for the targeted biopsy. So other than systematic, for targeted biopsy, you need this MRI. Accepted. चलिए आगे बढ़े. So what form of biopsy do you intend to do?
Sir, at
It
our
can-
institute, sir, we do transrectal ultrasonographic guided 12-core systemic biopsy, sir.
Not targeted?
So based on the MRI.
we do fusion biopsy.
फ्यूजन कौन गुप्ता जी फ्यूजन करना चाहते हैं?
और यहाँ पे हम लोग we have started doing.
No, you may have started doing, but is fusion biopsy indicated here?
No, sir.
Then why are you talking about it, Ankit? You see, please take this to utmost seriousness. There are very specific indications for fusion biopsy. Why do you want a fusion biopsy here? Remember, every wrong word will take you in a different direction of discussion. Okay, now people will want to know from you what are the indications of fusion biopsy.
Any apical lobe lesion or anterior or tumor located over the anterior zone.
Are there indications for fusion biopsy?
Sir, when we already have increased PSA, but already a previous negative biopsy, when we are not able to
Equivocal findings.
when we are not able to find equivocal findings in our DRE and elevated PSA, and already having a negative biopsy or fusion targeted biopsy would be.
So Ankit, this is what I mean. So don't talk more than what is necessary. देखिए आपने सोनोग्राफी में एक अलग चीज बोली, वहां डिस्कशन चला जाएगा. आपने फ्यूजन बायोप्सी बोली, वहां डिस्कशन चला जाएगा. So you will go away from the discussion about treatment of cancer prostate, and you will get stuck into these places which will be difficult to defend. Okay. So as Gite sir just now said, think twice before what you are saying. Every word you utter is important. Okay, so there is no place for fusion biopsy here. Okay, the question was asked only whether transrectal or transperineal. So stay in that area.
So the small suggestion is that there are multiple investigations or treatment modalities may be given, but in this particular patient, what is applicable, that is the most important thing. And that is what Dr. Pankaj Maheshwari is trying to tell you. You understand?
Yes, sir.
Huh? So every time whatever you are saying is not applicable. In this case, it is not applicable. So you decide now what you want. So my next question is, suppose nowadays if you don't do MRI, you can't do just PSMA PET scan? Ankit?
So we can do, but if the PSA is on a higher side and the DRE finding is suggestive of hard nodular prostate, and with the evidence of extra prostatic extension with fixed rectal mucosa, we can omit the MRI. But it is important to do MRI since we can get an accurate T staging and lymph node staging also.
So basically, you want it for anatomy.
Yes, sir.
So by chance, you are not sure whether it is extra prostatic extension is present or not at just now. So you want to find out whether it is a prostate confined or it is going out.
Yes, sir.
And that is why you want to do MRI.
Yes, sir.
Okay, fine. Go ahead, Harshit. Who is reading these images? Brijesh, you want to try?
Yes, sir. So this is a T2 weighted image of MRI cross section, sir. There are multiple hypo-intense areas over left posterolateral part of the prostate, sir. Left, next further. Yes, T2 weighted image also shows a small hyperintense area can also be noted on lower apical region of the prostate.
Sumit,
Yes, sir.
you want to add anything fast? Otherwise, we'll go ahead for the report.
So, no, sir. I mean,
Okay.
this finding. So
Okay.
there is extra prostatic extension seen over the.
Where?
Sir, in this image, the second row, third image, sir. So
HV also appears to be involved, sir.
so looks like infiltrating the seminal vesicles.
Yes, left
Yeah,
side,
the
left side.
right seminal vesicle, correct?
Yes.
Right. Okay, fine. Harshu, show them the report.
Yeah.
So the prostate is 4.1 cross 4.3 cross 4.4 centimeter, 40 cc in volume. There is a small well-defined area of 2.3 cross 1.3 cross 2.5 centimeter in the left posterolateral peripheral zone, involving the base, mid portion and the apex. There is restricted diffusion and significant drop on ADC. The lesion is involving the left seminal vesicle and abutting the adjacent rectal wall with maintained fat planes. And there are multiple nodules on both sides in the transitional zone. There is bilateral inguinal hernia with fat as content. Pyretes 5.
Okay, so what next?
So then, as per the MRI, the T staging is T3B, sir. And after that, I would explain the findings to the patient and then proceed ahead with do the workup for the biopsy, that is the coagulation profile along with the triple H markers, and then after that, go ahead with the transrectal ultrasonography guided systemic 12 core biopsies.
And I will also do the staging metastatic workup also for PSMA PET scan also, sir.
Now or after biopsy?
Before the biopsy, that we can have all the relevant information. Although it won't change our artifact रहेगा, but it won't change our management.
Yeah, line
The
of management.
Okay, slow down. So, when you are talking about biopsy, Samit, you spoke about coagulation profile. Do not forget to talk about urine culture.
So culture was no growth on.
कोई बात नहीं. I'm just summarizing.
Okay. Yes.
And always talk of systematic and targeted biopsy. इसमें उतना important नहीं है, but remember that. Okay. Ankit, there would be situations where we would do a PSMA PET before, but I would feel from exam point of view, first diagnose, then look at metastatic workup. Okay. Go systematically. It is no use directly doing a systematic workup unless you have the biopsy report. Okay.
Yes, sir.
ठीक है. बताइए, biopsy report बताइए.
On biopsy, 4 out of 3 cores on the left base had acinar adenocarcinoma with Gleason 4+4. Right side, there was no positive cores. And there was no lymphovascular or a perineural invasion found on histopathology.
Then the risk stratification would be done based on this, sir. So it will be a high risk, sir. And
why do you call it high risk?
So because the pattern is 4+4 and PSA more than 20 and cores are less than 50% positive, sir. 40%.
More than.
Here it is 40% less than 50.
It is 40, less than 50. Less than 50.
So it's a high risk as per the NCCN. So then after that, again after the risk stratification, I will explain the patient and then proceed ahead with the metastatic workup to do a whole body PSMA PET CT, sir.
Okay, and suppose you are in a situation where PSMA PET CT scan facilities are not available. What are the other options?
The CCT abdomen pelvis with contrast. CCT abdomen pelvis with bone scans.
Bone scan. Okay, good. So, do we have a PSMA PET? Hello.
It's just showing. 1 minute. Okay, so Gina,
Yes, sir.
like I want from all 4 of you, don't get biased. Now, what management you'll do? You want any other
Sir,
investigation, or you directly want to decide for the management? First, you decide for the management, and then I'll ask you how will you talk to the patient. Okay?
Yes, sir. So, elderly male with LUTS post URP status, with elevated PSA but with locally advanced CA prostate, with Gleason score of 4+4, that is grade group 4. I will convince him for external beam radiotherapy with short-term ADT, sir.
Okay. So, Samit, what is your?
So here would explain the patient and then sir as
First tell what is the TNM classification from
so
this?
here
What is the risk stratification? Okay. And
Yes.
what is the ideal management for that?
So here the TNM staging is T3B N0M0, and it's a locally advanced cancer prostate. And according to the NCCN, it's a high risk disease. So then I would explain the patient about all the findings, and then uh, uh, as the patient age is 72 or 75, and the Karnofsky scale is 80. So then I would here like to offer as a part of multimodal modality treatment or radical prostatectomy with ADT, sir.
Okay. Then Ankit, what you like to do?
Sir, in this PET scan, we have got incidental finding of right hydronephrotic kidney along with thinned out parenchyma. So first of all, I would like to do a DTPA scan for this patient. And this patient is also harboring multiple pelvic and callicial calculi. So I will explain the patient regarding this his disease, that he is harboring two disease. Either one is CA prostate, and another is right kidney, which might not be working properly. So we have to investigate regarding the same also.
Okay.
Yes, sir.
Fine. Brijesh, what you want to do?
Sir, as this patient is having clinically T3B with N0M0 disease with borderline serum creatinine, but no any lymph node met, sir. So I would like to convince patient with sympathy, empathy, and would like to provide him radical prostatectomy plus long-term androgen deprivation therapy. And concomitantly, I will convince him that he is having right-sided hydronephrosis. And prior to the operation, I would like to put a stent on the right side.
Okay. Fine. Ganesh Bhai, now your role starts. Dr. Ganesh Bakshi. Okay, let us see then. I think Samit has said that he will like to give radiation therapy. Correct?
No, sir. Radical
Sir,
prostatic.
Radical
I
prostatectomy.
told radiation, sir.
So Jina, how you justify? Why not radical prostatectomy, and why you want to give radiotherapy? What is an advantage, or what is the literature saying? What are the studies that says that radiotherapy in this case is better than radical prostatectomy?
Sir, one thing is MRI is showing that the lesion is above the rectal uh, margin, and but the plane is okay. Then there is TURP previous history, but 10 years back, and patient age is 72 years, and so with the Charlson comorbidity index, we have to stratify him before providing any treatment. But still, I would like to give EBRT because, uh, sir, RP in a locally advanced, sir, there are many meta-analysis and the studies on EBRT, and there is no much studies on providing RP in a locally advanced disease that will increase the cancer survival rates, or which will decrease. There are no much studies on radical prostatectomy. But there are studies that have proven which that the EBRT with the long-term ADT, because he belongs to the high risk, it has 10-year and 15-year survival rates better than our.
Okay. Dr. Ganesh Bakshi. Now they are saying, one is saying that radiation therapy, one is saying that and the other three are saying radical prostatectomy. One is saying that short term this thing hormonal therapy. One is saying long term. Of course, the management of the right kidney they want to talk. So how to go about? How will you explain them?
Is Dr. Ganesh muted? What is the problem?
We can't hear you.
Yes.
Ganesh, you are muted.
We can't hear you, Ganesh. No, we still can't hear you.
Ganesh is there. Is he talking? Ganesh, I think he has lockdown. He is joining again. Okay, so Ankit, why you are saying supporting radical prostatectomy?
Sir, first of all, we will have a final histopath report. The whole of the prostate will be removed in toto. Second, thirdly, the PSA will decline sharply. These are my and looking at his performance status, he is a candidate, and by his age, as per the Indian standard age, he may live more than 10 years. So that's why I am preferring for radical prostatectomy, sir.
So Samit, why you want to do radical prostatectomy?
So same, we will get the accurate staging along with, and if there is positivity for any margin or there is recurrence, then it would be treated solely with help of adjuvant radiotherapy. And the performance status is good and the expectancy is more than 10 years without any significant comorbidity. So I would like to offer him radical prostatectomy.
Brijesh, you want to add anything?
No, sir.
Any extra?
No,
No?
sir. He is not having any other comorbidities rather than raised creatinine. He can suffice more than 10 years, sir. And by doing radical prostatectomy, we would be providing him with better care because all the disease would be removed and there will be less chances of metastatic burden in the future, sir.
And
if,
sir, also his LUTs would be cured.
So say like that,
The-
na? That
Yes,
he
sir.
has got obstructive symptoms also.
Oh,
Number one, he has got. You can see his uroflowmetry, even though it is he's not doing total history, but uroflowmetry is showing there is obstruction. Number one. Number two, you are preventing means there are less chances of local uh, problems because of the enlarged prostate. Correct? Obstruction later on, bleeding, or upper tract involvement. So all these things are also you're going to avoid. So in your answer, you have to add these things also.
Acha, you can hear me now?
Yeah, now
Yes,
we
sir.
can hear you,
I
Ganesh.
don't know. I just re-logged in. I was logged in all the time. Sir, I just wanted to confirm the age was 72 or 75?
72.
So 72 with high risk localized. No, I didn't understand why we are seeing matlab, locally advanced. There was something in the MRI. It was just
T3
abutting the rectum, no?
So
It is
involvement of seminal
seminal
vesicles,
vesicle invasion.
T3V.
Okay. So what happens is, I think we have moreover started using MRI as the staging thing, but actually the staging still depends on the DRE. I mean, if we really do get that, what to say, if we really do get
Seminal
seminal
palpable.
vesicle involvement on basis of the DRE, which we usually maybe sometimes we realize, but sometimes we don't. So going on this, at least we would say that he is high risk localized 72-year-old, which is not probably a very old age. Having had TURP 10 years back is okay, like, so won't have a great problem. Whatever is the post TURP situation would have long healed and resolved and everything. So if he has LUTS, and I think there was some obstructive problem also in the uroflowmetry. So I would say that maybe if it is a big prostate, go for a radical prostatectomy. But considering high risk lesion 4+4, I would explain right in the beginning that there is a chance of needing radiation therapy as per the post-operative histopathology report. I mean, not immediate, obviously, but at some point in time.
Sir, can we do before going for surgery? Can we go for cystourethropy because he had undergone TURP, so there might be some chance of urethral stricture disease, matlab urethral stricture or BNI. Matlab, I just have a doubt, so that's why I have asked, sir.
I think your presenting symptoms were all the storage symptoms mainly. I mean, they were not very strongly obstructive voiding symptoms. So I don't know. Matlab, let's ask Dr. Pankaj or somebody. I mean, not a routine, unless there is a strong history, not a very routine thing to do.
Yeah, the only
But
thing is
Because
just see the uroflowmetry. Harshu, just show them the uroflowmetry.
patient
that is a
patient
poor flow, now 5.4
yeah.
average is quite
So
bad.
yeah, but it is not a box type. So Ankit,
Acha, you're showing the graph. Okay, so
graph.
that is not the picture of a stricture urethra.
Yeah, it's not
Okay.
appearing. Plus, he has
And
got an enlarged prostate. If you
hmm,
go to see,
and
even after
sometimes, like,
TURP.
just adding on to a practical thing on your question, if this TURP would have been done, like, say, something like 3 months or 6 months back, then I would have probably done a cystoscopy just before, on the same day of radical prostatectomy, just to check how near are the ureteric orifices at the bladder neck. How is the resection done by the original surgeon? Because that might matter to me. I will get a very big bladder neck in that case, probably. And
Correct.
by chance, when I try suturing or I try to fish mouthing the bladder neck, I might just suture off the ureteric orifice. So I would definitely see that. But
Yes.
that's probably a practical point. It's not of the exam point.
I really appreciate this. That after TURP, this is very important. I think even if we are doing after 3 months or 6 months, now from next time I will also do the check cystoscopy first.
See, sometimes the orifices are really near.
Very nearby.
And
And
sometimes the other thing is you might really do a fish mouthing to reduce the size of the bladder neck. And in that, when you take sutures inadvertently, you will take the ureter.
correct. A good practical point.
Dr.
Fine.
Gaurang,
Bolo.
say I'm Dr. Chaudhary. Can I ask a
Yeah.
question?
Yeah. Please. Go ahead.
Thank you. No, my question is to Dr. Ganesh. Can you just elaborate it more precisely? The comment he made about the staging. Does he not give a more importance to the MRI finding here and rather believe more on the local DRE findings?
No, it's not like that. We obviously believe the MRI when we get to the surgery mode. But then it is a known fact that T3s we operate very often today. There was a
Mm-hmm.
time when we used to restrict the radical prostatectomy 15 years back only to T2. So that is no longer followed now.
Okay.
So when I counsel about such a patient, we always say that it is high risk localized and we group together locally advanced disease. So these both categories come under the same group. But you will have to take a patient by patient call. Suppose if my locally advanced has lymph nodes positive or gross some extra prostatic disease, then the same management cannot be said. Involving the rectum also will be locally advanced only. But I may not do the surgery in that case.
Fine.
Okay.
So Gina, do you know any study which supports your theory? And suppose
Sir,
if your patient has opted for radiotherapy, how will you manage it?
Sir, I would go for IMRT with image guided radiotherapy also, with hypofractionation of the cycles to so for the prostatic bed, and considering it as a high risk disease, also can go for a pelvic node, but still I would restrict to the of to the prostatic bed, sir. And will be a, sir, I think it is 64 grays with
So, but now
hyperfractionation, sir.
all this I agree, but have you seen the uroflowmetry? It is in
Yes,
front
sir.
of you.
Yes, sir. He's having symptoms also.
So what you
I
like to
would
do
tell
first?
the LUT symptoms will increase, but the acute gastrourinary symptom will genitourinary symptoms will subside, but still he has a chance of long-term side effects also, sir. Yes, sir.
No, no. So
Sir,
before,
I told the RT because just because it was abetting the rectal mucosal wall, Uh, but maybe I should.
no, before doing RT, you will like to do Scopy or read TURP.
Yeah.
I can go ahead with alpha
You can know
treating him
whether
with an
you'll do
alpha
it or
blocker.
whether you'll do it or you will
Yes,
not
sir.
do it.
I'm considering an RT. If I'm considering RT to subside to reduce the symptoms, I will give an alpha blocker C for the Euroflow, and then if he is still not with the symptoms, if it is not subsiding, then I can go ahead and TUR to reduce the median lobe, and then I can go for. So now the radiation has improved with the IGRT, where we can just locate the peripheral zone and give radiation, but still some side effects will be there because of the TURP fossa being empty, prostate fossa being empty. But still, I can try this, sir. Alpha blockers, and then followed by a review uroflowmetry. And if it is not subsiding, I can go for TURP also.
Okay. So Ankit, do
So,
you have any? Yeah, yeah.
sir, I just wanted Ganesh Bhai to throw some light on the studies regarding radical prostatectomy versus radiotherapy, because Gina made a comment saying that there is not much data on
No, so there
radical
is an
prostatectomy.
SPCG 15 which is accruing
PCG
patients.
15.
No,
Yes.
they
And
have in exam, Gina, if you are telling positive, negative side of each and every section, so the question is straightforward कि उसका रोल है कि नहीं है, तो है तो बोलो, नहीं तो नहीं तो बोलो. हर चीज में तुम दोनों साइड अगर बोल रहे हो तो सामने वाले को कुछ भी कहो, आपको क्या कहना है पता ही नहीं चलता है.
You understand, Gina, what sir is
Yes,
saying?
sir.
Like in
Yes, sir.
this case, you can say, "Okay, sir, this case patient, even though he has undergone TURP, he has got, and he is telling that more of the he has got a storage problem symptoms, but here the graph is showing he has got obstructed flow. I will definitely like to treat his outflow obstruction. So it may be alpha blocker not improving. Then I will do cystoscopy and find out whether there is a stricture or a prostate. I will treat that first and then I'll start radiotherapy.
Yes.
It's very simple. No
Yes,
confusion.
sir.
You understand? This is a how you're, because
Yes, sir.
otherwise it appears that you people have read, but you don't have any practical knowledge.
so
Sir,
Hiren, I think Hiren had asked a question, no? So
Yeah.
SPCG 15 trial is a ongoing trial, Scandinavian multicenter, phase 3. And that will actually answer the question. But the inclusion criteria in that was T3, T4, but N0. So although we call locally advanced, it is clearly N0. So they have not defined N plus as locally advanced and non-metastatic otherwise. So the standard arm which is being thought in that study is radiation therapy combined with neoadjuvant and adjuvant. So NHT, RT, HT is the standard arm. The experimental or the arm which is to be explored is the surgical arm. radical prostatectomy, and possibly followed by radiotherapy, which is early salvage or salvage. And the question is the same. Overall, does it improve survival? The surgery improve survival over the traditional therapy, which was radiation therapy?
Right. Thank you.
So estimated result will be in 2029 or something like that, 30.
Sir, I have one doubt.
Yeah.
Sir, before, like, if you are opting for radiotherapy and before that, along to treat the lower urinary tract symptoms, you are giving alpha blocker. So if you are waiting, so we have to start with the ADT also, right, sir? Or
You have to start with ADT. That is for sure. Again, I think last time I mentioned that if the person is having grossly obstructive symptoms which are not being relieved by alpha blocker, maybe checked on a uroflowmetry like this, then you need to probably do a channel TURP or a good TURP. Wait for that wound to heal and then go for radiation.
yes.
Yeah.
So in the prior time, we give something what is called as neoadjuvant hormone therapy. Neoadjuvant because the actual treatment is radiation therapy. So before that is neoadjuvant and after that is adjuvant.
Yes.
So if someone asks you, is there any role of neoadjuvant chemotherapy, okay, in CA prostate, then you can talk about this, okay? So whenever there is an obstruction and you are planning for a radiation therapy, curative, you can give. Fine. So Ganesh bhai, anything else in this you want to ask?
No, but one thing like still today TNM has not changed DRE as the method of T staging. However, they acknowledge that MRI is more accurate, obviously, and MRI is more likely to find T3 disease in whenever you do an MRI for a high risk or a high risk classified by D'Amico et al. All the three features which are high risk.
Okay. So Ankit, you want to add anything?
Sir,
Any study, anything which you are aware of?
no, sir. I am not aware.
Dr. Gaurang,
Yeah.
were you talking about neoadjuvant chemotherapy or ADT?
ADT.
ADT, ADT.
ADT. Okay.
ADT. So can we go for a second case? Amandeep is going to join, Ganesh.
He said he'll join at around 10 o'clock, I think.
So can we just ask him?
We'll ask him. Maybe I had just asked him 15 minutes back.
Okay. Okay, then I think we'll go ahead with the second case, and if he joins, then we will wait for his presentation because it is very, appropriate for this second case. Harshu?
Yes, sir. Just loading the slides.
Yeah.
The second case is of a 68-year-old male with daytime frequency and nocturia for 1 year, overflow for 6 months, and urgency for 3 months, associated with lower back pain and hip pain for 6 months, and loss of weight and appetite since 6 months.
Yeah. So Gina, this is a history.
sir.
How will you elaborate?
Sir, I would ask for the onset and progression of each and every symptom. And I would also ask about the other previous any interventions or lithuria or pyorrhea or hematuria in the past. And I would also elaborate this loss of appetite and loss of weight. What is the significant? Whether I will ask for the previous weight and whether I will see whether it is significant or not. And also, I would like to ask about the previous any urological interventions in the past. And has he taken any treatment for the same, the LUTS symptom? Has he been evaluated prior? Because since 1 year he's been having symptoms, has he been evaluated for prior? I'd like to ask all this history, sir.
Okay, Harshi, show her the history. So, Gina, just see how systematically they are writing, and this is the flow you must maintain in your exam. Huh? Just see.
Yes.
Yeah, Harshi.
The patient was relatively asymptomatic 1 year ago, after which he started developing frequency, which was 3 to 4 hourly, now progressed every hourly. Nocturia was 1 to 2 times per night, which increased to 3 to 4 times per night. Poor flow was first noticed 6 months ago. Flow has been progressively decreasing and associated with heavy void. Urgency was first noticed 3 months ago, which was occasional. Now he has urgency almost every time before he voids. It was associated with bony pain at lower back and hip on and off since last 6 months, which was dull, deep, and persistent ache, worsening at night to end with movements. A significant unintentional weight loss of about 10 kgs in last 6 months and loosening of clothes. Loss of appetite in 6 months, reduced to almost half. IPSS score has frequency 4, urgency 5, nocturia 5, and poor stream 5, 19 out of 35. Quality of life 4 out of 6, patient is sexually active.
Yeah.
There is no history of burning, micturition, hematuria, lithuria, dysuria, pyuria, no fever, abdominal pain, nausea, vomiting, no intermittency, retention, incontinence, or hesitancy, no previous instrumentation or catheterization, no history of jaundice, facial puffiness, exertional breathlessness, lower limb edema, bleeding disorder, anticoagulation therapy, or blood transfusion, no radiation or chemotherapy. Patient is a known case of diabetes and hypertension, taking dapagliflozin 10 mg and metformin 5 mg, along with amlodipine 5 mg. No past surgical history. Patient has bladder habits altered, sleep disturbed due to nocturia, and he is a non-smoker, non-drinker, and a non-tobacco.
So, Ankit, this is a history now.
Yeah.
Just summarize and tell us.
A 68-year-old male with the chief complaint of mixed legs with pain in lower back with significant loss of history with IPSS score of 19 by 15 and his known case of diabetic and hypertension. Sir, my probable diagnosis will be bladder outlet obstruction, which may be due to enlarged prostate, which may be malignant or benign, or outlet obstruction, which can be due to stricture disease also. Or still the patient is diabetic, my lower down my diagnosis will be neurogenic bladder also. And next, I would like to examine the patient to confirm to exclude my differential diagnosis, sir.
Okay, so what are the 3 diagnoses you have given? One is the enlarged prostate, correct?
Yes, sir.
Maybe
Yes, sir.
either
Which,
benign or it can be malignant. That is number
yes,
one.
sir.
Second
Yes,
is the
sir.
neurogenic bladder,
Yes,
correct?
sir.
And the third
Yes,
one,
sir. Stricture disease, sir.
urethra. So,
Yes, sir.
how will you rule out from this history? What are the? Is there any positive point which is suggestive of stricture?
There is no history which is suggestive of any instrumentation in the past, sir. So this will rule out my stricture disease, and and uh, uh, and the and by examination, I would like to rule out my other 2 diagnoses like bladder outlet obstruction and other diagnoses, sir.
Okay, fine. So now what you want? You want to do the examination.
Examination, sir. I would like to examine the patient, sir.
The patient is a diabetes also, correct?
Yes, sir. Yes, sir.
You want to change any medicine?
Yes, sir. Sir, patient is on SGPLT2 inhibitor, which is more prone for glucosuria and which can cause UTI in patients, sir.
Okay. And even metformin, if you are going to do any contrast.
Sir, yes, sir. If I am planning for contrast study and then for these 2 medication, I would like to consult my endocrinologist team and would like to change the medication accordingly, sir.
Okay. Harshu, show them
Sir, Amandeep
examination.
has joined.
He has joined. Amandeep, can he share the screen?
I mean, we can stop and he
Ah.
can present. He has joined.
Harshu.
Yes,
Sir,
sir.
I just joined. Would you want
Yeah.
to start right now or?
Yes. Because we are going on that case only. So once you show them, then we can, you can ask them the questions on the same case.
Okay.
Harshu, you can.
All right.
You will
So
have
then
to
should I
stop
share
sharing.
my presentation and share my
Yeah.
screen, start presenting? Okay.
Harshu, you will have to stop.
Yes, sir.
Harshu, we'll have to stop now.
Okay. Is it seen, sir?
Yes, we can
Yes.
see.
Okay.
Screen
So
is seen.
this is like a longish presentation about the entire workflow for a patient who comes with metastatic prostate cancer. Do we have the time to go over it?
Yeah, go ahead.
Okay, all right. So, good evening, everyone, and I'm really sorry I joined late, and also sorry to the candidate who was presenting that I've cut you short. We'll go over metastatic hormone-sensitive prostate cancer. I'll go over it like a case with multiple things that we do in the clinic for such patients, and anyone from the seniors also and the students can stop me in between and ask me something if something is not clear, or if they have a doubt. Bakshi sir, also let me know if I should skip something if it is too much in detail.
I think let's have that full 83 or 63 slides, whatever.
Okay.
No problem.
All right.
They will always learn something in that.
Yes, sir. Okay. So, very typical history, elderly patient, 70-year-old, ECOG 1, no significant family history. Around 10% to 15% of our patients would have a significant family history. We will see what that is later. No comorbid illnesses for him. He was having some lower urinary tract symptoms, so underwent some investigations, saw a urologist, and the PSA came out to be 254. That is usually how patients come to us with a raised PSA or a very high raised PSA. Now, what about the prostate biopsy? Is MRI to be done prior to the biopsy in this patient? The thing is, for a 254 PSA, we are already thinking on the lines of metastatic prostate cancer. You should understand why we do MRI prior to biopsy. We do the MRI prior to biopsy to see from where to take the biopsy in the prostate, and to also check if we can avoid doing the biopsy in a patient. Now, in this patient who has a grade 3 hard nodular prostate, we don't need the MRI to guide us from where to take the biopsy. There is no doubt that a biopsy has to be taken, and hence an MRI is not necessary in this patient. But if this patient had a PSA of 25, we would definitely do the MRI before proceeding to the biopsy. Now, how many cores in our patient? Now, because we kind of know that our patient is having advanced prostate cancer with our DRE findings and the PSA, it is not necessary to have 12 cores. Okay. Some cores, just to prove and confirm that we are dealing with prostate cancer, would be enough. In our patient, we found out that we were dealing with Gleason 9 disease. Now, what is the evidence for MRI prior to biopsy? This is not for metastatic prostate cancer, but these are the studies. PROMISE, Precision, 4M and MRI first is what the guidelines have. Now, patients in these trials had PSA up to 15 and very few had an abnormal DRE, and that is why we do an MRI prior to biopsy for patients who come to us with marginally raised, borderline raised PSA and not PSAs of hundreds and 200s. So that is why we perform MRI before prostate biopsy in men with suspected organ confined disease. Okay, and in men with locally advanced disease suspicion on your clinical examination, you could consider limited biopsy without the MRI also. Now, once we have the PSA of 250 and the biopsy saying that there is Gleason 9 disease, we obviously need to stage our patient. So what we would do is a PSMA PET CT. Now, should we even be discussing this question, CT versus plus bone scan versus PSMA PET CT? We've moved on from that. Till a few years back, we would discuss whether we should be doing CT plus bone scan or a PSMA PET. Right now, in our country, cost for both these scans is pretty much the same. All our treatment decisions are based on PSMA PET CT, even if we do not have level 1 trials with PSMA PET CT. So we would do a PSMA PET CT for our patient. There is no other answer. Now the thing is, what if your patient has come to you with a CT and bone scan done? Now, if that scan is showing florid metastatic disease, there is no real need to do a PSMA PET scan. But your future scan later on during therapy and follow-up would be a PSMA PET CT. So you could still consider having a baseline PSMA PET at baseline so that you can have comparison done at 3 months and 6 months. But it is not mandatory if your bone scan is showing you florid mets. So this is how bone scan and PSMA PET compare. Just know that the figures of sensitivity and specificity are in the high 90s for PSMA PET when it is about detecting bone mets. One line which the guidelines say that that doing PSMA PET CT over a bone scan and CT has not shown to impact survival outcomes and the outcomes on treatment. So fine, this disclaimer is there because the trials don't use PSMA PET CT, but in our clinical practice, PSMA PET CT is the go-to investigation. If you say this as your answer in exams, I don't think anybody nowadays is going to counter you and ask you why not CT and bone scan. Now, what if the patient has come to you with an FDG PET CT? Because that is sometimes done in some places. What would you do? We would want to do a PSMA PET CT. Why not an FDG PET CT? Now, if the FDG PET CT is showing you again florid mets, then you may not do a PSMA PET CT. But why do we not usually do an FDG PET scan in prostate cancer patients is what you should know. We do not do it because FDG relies on glucose metabolism of the cancer cells, and prostate cancer typically is a slow growing cancer unless it's a very, very aggressive cancer, and that is why FDG PET CT does not always pick up all metastatic disease, and hence we do PSMA PET CT for staging prostate cancer. Now, is there any role of doing an FDG PET CT in our patients of prostate cancer? Now, you also need to be aware that the main type of prostate cancer that we find on biopsy is adenocancer of the prostate, and then we assign a Gleason score. Sometimes patients with advanced Gleason 9, Gleason 10 disease, and especially when they have a lowish PSA, can also have a neuroendocrine component. Now, neuroendocrine component, if it is the dominant component on the biopsy, if that is what the pathologist is telling us, then probably an FDG PET CT has to be added to the PSMA PET CT to adequately stage the patient properly, because PSMA PET is then not going to pick up the neuroendocrine component, and neuroendocrine disease is prone for having metastatic disease. Now, what if the PSA was 5.8? What is a PSA non-secretor? So less than 10% of patients are PSA non-secretors, which means that they would have advanced disease on their scans and even clinically, but they are not producing a lot of PSA, right? So in such patients, we would still do a PSMA PET scan if our biopsy says that it is adenocancer of the prostate. If somehow the biopsy says that we are dealing with majority of neuroendocrine component, then we would think of doing an FDG PET scan, but that is again a rare scenario. And you should also probably remember that patients who do not produce a lot of PSA tend to not do as well as patients who produce a lot of PSA. So if I see a lot of disease on the PET scan and somebody has a PSA of 1000, I'm happier than him having a PSA of 10 at baseline. Now, so we have the PET scan report also with us. Now we have to risk stratify our patient. So the volume and the burden of the disease matters. And do we take into account the non-regional nodes? So what are non-regional nodes for prostate cancer? Everything common iliac and above is non-regional. Pelvic nodes are N1, common iliac nodes are M1A. Everything else in the retroperitoneum, supraclavicular nodes are all M1A. They are not taken into account when we talk about low volume or high volume disease, because the low volume and high volume was defined on the basis of CT plus bone scan, and it only took into account bone mets. Do we use the term oligometastatic prostate cancer? So yes, this term is used in clinical practice, in conferences, in some papers, but guidelines don't tend to use this term. Usually oligometastatic means up to or less than 5 mets. And this term of oligometastatic is probably the same for all cancers in the body, where we would go up to 5 mets to call something as oligometastatic cancer. So for prostate cancer, we stratify based on the volume of the disease as per the charted criteria. So this trial used docetaxel along with androgen deprivation therapy, which we'll see later. And these are the criteria. You would call somebody as having charted high volume disease if the patient has 4 or more bone mets, including one or more outside the axial skeleton, which is the vertebral column of the pelvis. And if somebody has visceral mets, which means lung mets or liver mets, that patient automatically becomes charted high volume. If these things are not present, your patient is a charted low volume disease patient. Now, charted used CT plus bone scan, but we in clinical practice have extrapolated it to PSMA PET CT. So we would still apply the same definitions and the same numbers to even the PSMA PET CT that we do. Why? There is no answer to this question. We just do it that way. Now, florid mets on the PSMA, right? So our patient, if that patient with 254 PSA and you've done the PET scan has florid mets, so we would ideally do the PET scan after the biopsy. But if the PET scan has been done before the biopsy, would you then still want to do a biopsy if there is a lot of disease on the PSMA PET scan? So the thing is, we had presented our data from TMH at AUA 2018 around 8 years back, where we said that in patients who have florid disease on PSMA PET CT, not even a single patient did not have prostate cancer when we did the prostate biopsy. So probably prostate biopsy is not required. But for all medical legal purposes, we still do a prostate biopsy. We don't take 12 cores as I told you. We probably take 1 or 2 cores from each lobe. Another thing that you could do is if somebody has a UTI, has an indwelling catheter, is not willing to undergo that pain and everything, you could consider biopsying any metastatic site. A supraclavicular lymph node, any pelvic lymph node, USG guided, any bone site can be hit. All you need to do is prove that the patient has prostate cancer. When you do biopsy from a metastatic site, the pathologist is not going to be able to tell you the Gleason score for the patient, but that does not matter anywhere when you treat a metastatic prostate cancer patient. Okay, so in our patient, we had PSMA expressing metastatic pelvic lymph nodes. So the patient was node positive. And we also had PSMA expressing metastatic retroperitoneal lymph nodes, which are non-regional lymph nodes. So the staging for our patient was N1, M1A. He did not have any bone mets. Okay. Now, does a comparatively low PSA worry you? As I told you, yes. A highish PSA which corroborates with what you are seeing on the PET scan is good instead of having a low PSA but high disease on the PET scan. But when you do see something like this, then you would probably want your pathologist to go back to the slides and check for something else like a neuroendocrine component. You would suspect neuroendocrine cancer if the patient has visceral only mets, like there are no bone mets but a lot of liver mets, multiple mets with no PSMA uptake, then you would probably also want to do the FDG PET scan as we spoke. And if you are having rapid progression after an initial response to the treatment that you do, think of having probably missed neuroendocrine cancer at baseline. Okay, now the first thing that we want to do for our patient, so our patient is charted low volume patient because our patient does not have any bone mets. He just has non-regional lymph nodes. So our patient is a low volume metastatic prostate cancer at 71 with Gleason 9 with PSA 250 at baseline, non-regional lymph nodes on the PET scan. Now and a catheter in situ. Now what do we want to do for our patient? What we want to do first is androgen deprivation therapy. Now these are the options that we have. We can either do an orchidectomy or use LHRS agonists or antagonists. We'll see them in detail. We decide based on patient factors like the performance status, whether the patient is on any blood thinners, whether there is any cardiac history, and obviously the finances, and also disease factors like an impending cord compression, which is not there in our patient, and severe voiding LUTs. Our patient happens to be in retention with a catheter. Now, just one slide about Charles Huggins because he's somebody who got a Nobel Prize. For what he said that prostate cancer is influenced by androgenic activity. Disseminated prostate cancer is inhibited by eliminating androgens, and he laid down the basis for hormonal manipulation of prostate cancer. And this paper was published in 1941, and this is still what we do even 65 years, 65 years after the paper was published, 85 years in fact after the paper was published. So this is the androgen pathway. The hypothalamus releases GnRH, which then acts on the pituitary to release FSH and LH, which LH then goes and acts on the testes to release testosterone. FSH acts on Sertoli cells. LH acts on the Leydig cells for testosterone to be produced. And then testosterone acts on the androgen receptor wherever there is androgen receptor at the metastatic sites and even in the prostate. So GnRH antagonists, Degarelix, does this. It blocks the production of GnRH in the hypothalamus. What do the GnRH agonists do? They increase the production of GnRH. So finally, over time, because the feedback mechanism is lost, the FSH and LH production by the pituitary goes down. What does orchidectomy do? We remove the testis, so there is no testosterone produced. And what do anti-androgens do? They act directly on the receptor. So we have something that we can do at every point of the androgen pathway. Let's talk about orchidectomy. So the rationale is that 95% of testosterone is produced in the testis, hence knock off the testis and the patient becomes castrate. It is the fastest way to reach castrate levels within 6 to 12 hours, max 24 hours. Very economical, and it is just a one-time cost to the patient and can even be done under local anesthesia. Disadvantages: it is permanent castration, and for most of our metastatic prostate cancer patients, we do aim for permanent castration. Occasional patient with a wound infection can land up, that is a drawback of doing an orchidectomy, and some patients could have psychological issues that they do not want to lose their testis. In these patients, you can try a subcapsular or an epididymis sparing procedure. What about GnRH agonists? So what are they doing? They are causing a sustained increase in the level of GnRH in contrast to physiological pulses. So the sustained increase then leads to downregulation of the GnRH receptors in the pituitary, as I told you, and there is decline in the production of LH and FSH. The initial GnRH flare causes a flare phenomenon which can last for 15 to 20 days, and that is why if you start agonists, you need to cover this flare with an anti-androgen. We do that with bicalutamide. It is given 50 mg once a day for 3 to 4 weeks, and castrate levels are achieved in 2 to 3 weeks. So GnRH agonists are very commonly used in our practice. We just avoid using them when we want immediate castration to be achieved. Right, so various formulations are available. We have leuprolide, triptorelin and goserelin. We commonly use the 3-monthly leuprolide of 22.5 mg or the 6-monthly 45 mg. There is also a 4-monthly 30 mg formulation available. Triptorelin, we use the 11.25 for 3-monthly. It is not 22.5 for 3-monthly. So that is the dose difference between leuprolide and triptorelin. Goserelin, only one dose is available, 10.8 mg, which is 3-monthly. And the annual cost would be about 40 to 60,000 rupees, depending upon what brand and generic versus the original brand. Now, what about GnRH antagonists? So the mechanism of action is suppression of GnRH levels at the hypothalamus, as we saw. So there is decrease in LH and FSH, and hence testosterone is not produced. There is no flare phenomenon, so you do not need to cover with bicalutamide. And LH levels fall by 84% within 24 hours. The patient becomes castrate. Around 90% levels fall within 10 days. Injection site reactions are known because this is taken as a subcute injection on the anterior abdominal wall. Patients do have some pain, swelling reaction at those sites, and we ask them to use some hot fomentation or cold compresses. The loading dose is 240 mg. So remember the dose, it is 240 mg, and then a monthly maintenance dose of 80 mg. It is given as a subcute injection, as I told you. It is the most expensive of all three that we have. So the annual cost is around 1.5 lakhs in the first year. Then 1 lakh a year. The initial cost is because of the 240 mg loading dose. And we also have relugolix, which has recently been approved, and it is also available in India. The HERO trial is what told us about relugolix. Relugolix is taken as once a day tablet. I think the dose is 360 mg as a loading dose on day 1, followed by 120 mg taken every day. It is also being commonly used in clinical practice. So between degarelix and relugolix, if you want to use an antagonist, any of the two can be used. Now, there is a lot of discussion about having cardiovascular risk with GnRH agonists. So agonists lead to an increase in LH and FSH, right? At least transiently, and then they fall. So the increased FSH has been postulated to lead to plaque rupture and cardiovascular events. And this risk is especially higher in patients who have a plaque. So somebody who already has a cardiovascular event history is at higher risk. Orchidectomy also leads to a higher FSH. Just imagine when you're doing orchidectomy, testosterone production goes down. So there is no feedback to suppress LH-FSH. So LH-FSH actually goes up after the orchidectomy has been done. But because not a lot of studies have been done in the Western population with orchidectomy, we do not know a lot about cardiovascular effects with orchidectomy. Now, so we had this paper about cardiovascular morbidity with GnRH agonists and antagonists. So You can leave aside that. Let's just look at these two lines on the right hand side. The final conclusion.
पापा को ना ड्रिंकिंग की बहुत बड़ी प्रॉब्लम थी करवा दो नहीं डांटो तो लाइट
Okay, so we'll just. Can we ask Tanvi's iPhone 16 to be muted, please? Yeah. So just look at these two lines on the right hand side. Men with no pre-existing cardiovascular disease at baseline, there is no difference in the incidence of cardiac events. So you can use an agonist, antagonist, depending upon patient's preference, financial ability, everything. But men with pre-existing cardiovascular disease at baseline, significantly fewer cardiac events or deaths in patients receiving the antagonist. So Degarelix is supposedly safer than the agonists in patients who have an existing cardiac history. This is something that you should tell your patient. Now, there are some other options. We can do bicalutamide monotherapy, 150 mg/OD. What was the dose of bicalutamide when we were combining it with leuprolide? 50 mg/OD. When you use it as monotherapy, it is used at 150 mg/OD. Nobody uses it right now. It's just for naming. And ketoconazole and Honovan were used in the past. We do not use them now. Now, how would you choose if you have an impending cord compression, like an impending indication to become castrate, to make the patient castrate? You would do either orchidectomy or use Degarelix. If you have a large gland with severe voiding LUTs, you would either do orchidectomy or use Degarelix. If you have high risk of cardiovascular events, I put a question mark there because it is still not crystal clear. But if financial ability is not a problem for the patient, then choose the antagonist over the agonist is what I would say. And if you have none of these other factors, decide based on patient's affordability and preferences. Now, this is something very new. This is March 25th, 2026, just 2 months back. So what are we doing? This is about transdermal estradiol patches in locally advanced prostate cancer. Okay. So I'll tell you what the rationale is. So when we do androgen deprivation therapy with LHRH agonists or antagonists, finally what happens is we end up suppressing testosterone. So that leads to erectile dysfunction, loss of muscle mass, loss of muscle strength. That just has to happen because you're reducing testosterone in the body. But in males, peripheral testosterone in the peripheries also gets converted to estrogen. So when the testosterone level goes down, estrogen level also goes down, because 80% of estrogen in the body is synthesized from testosterone in males. And because of estrogen going down, these are the things that happen: osteoporosis and increased fracture risk, lipid changes, fat deposition, insulin resistance, memory loss, and the hot flashes. This is all because of the estrogen going down and not because of the testosterone going down directly. This is an indirect side effect of the testosterone going down. So if somehow you can only have the testosterone going down but not have the estrogen going down, would that not be good? So how can you do that? You give exogenous estrogen. So you give estrogen to the patient. The estrogen causes negative feedback on the hypothalamus. So the GnRH goes down, the LHFSH goes down, testosterone production goes down, and you achieve castration. Is that clear? So you are giving exogenous estrogen and reducing testosterone. This, because now you have a lot of estrogen in your body, even if the testosterone has gone down, estrogen has not gone down. So the side effects of estrogen depletion don't happen. Now, if you give the estrogen orally, like Honavan, oral estrogen causes thromboembolic toxicity because of first pass hepatic metabolism. So you want to give estrogen to the patient, but not orally. You want the drug to get directly absorbed, and that is why you use transdermal route. So patients are given transdermal estradiol patches, because of which estrogen is absorbed into the blood, bypasses liver metabolism, thromboembolic events don't happen, estrogen level goes up in the body, testosterone level goes down in the body, loss of muscle fatigue happens, but low estrogen related side effects do not happen, which used to happen with conventional androgen deprivation therapy. And now see the title of the paper: transdermal estradiol patches in locally advanced prostate cancer, right? So what are they doing? Let us come back to the paper. They used, so this paper is only about non-metastatic patients. Okay, although I do see that this may come into practice for metastatic patients also. So they had 1300 patients. They randomized them to get estradiol patches every day or the LHRH agonists. So first thing was to see that your efficacy is not going down because you are removing androgen deprivation with the injections. So the primary endpoint was metastasis-free survival, and the metastasis-free survival did not change, which meant that using estrogen was as good in terms of efficacy as using the injections. And the castrate level of testosterone was also the same in both the arms. What you wanted to do by giving estrogen was to avoid the side effects. So the hot flashes happened in only half the patients when you gave transdermal patches compared to 89% patients when you gave the injection. But one side effect, particular side effect of using transdermal estradiol patches is that the patients have gynecomastia because of the increased levels of estrogen in the body. So this is something new which has happened in the last 2 months, which you should just have an idea about. Now, coming back to ADT, would you use intermittent ADT? Now, by default, you would want to use continuous ADT. So when would you want to think of intermittent ADT? Firstly, your patient has to be on injections. If somebody is on orchidectomy, then they cannot think of intermittent ADT. In patients on injections, if they have achieved a very deep response, which means that the PSA at 3 months or 6 months is in single digits, less than 1.1, that patient has achieved a very good response with the therapy. And if that patient has some side effects, you could have a discussion of withholding the ADT for some months to allow the patient a drug holiday, a holiday away from side effects, and then the PSA would definitely go up in some time, and you decide a threshold of 1, 2, and then start the ADT again. So you give the patient time off the side effects. This is not done in patients who don't have side effects. Do you need to cover with bicalutamide if switching from degarelix to agonists? So you have given degarelix as 240 mg loading dose because your patient had cord compression, and now after 1 month, instead of giving the monthly injections of degarelix, which are expensive, you want to shift the patient from degarelix to leuprolide, which is a 3 monthly dose and not as expensive as degarelix. Do you now want to give bicalutamide because you give bicalutamide at baseline with leuprolide? The answer is no, because you have achieved the castrate level with degarelix. Now giving leuprolide is not going to cause a flare. Any role for combined androgen blockade, which means combining ADT with bicalutamide, apart from covering the flare phenomenon? The answer is no. How common are the hot flushes? About 15-20% of our patients can have hot flushes. Why was it 89% in that trial which I just showed you? Because that was a trial which is proactively asking patients for these complaints. In our clinic, we usually do not ask patients about these complaints very routinely, and nor do patients talk to us about these complaints. But some 10-15-20% of our patients would come to us and tell us that they have hot flushes, and the number would be higher if we proactively ask them. The management is giving them megestrolol acetate, SSRIs, pregabalin, or do intermittent ADT if the disease allows you to do it. Now, what about our patient coming back 71, no comorbidities, PSA 254, Gleason 9, low volume disease on the PSMA PET? We did a bilateral orchidectomy for our patient. Okay, now is that enough? Now, some years back it was enough. Today it is not, and you need to do something called as add-on therapy. So what are the options available? We will see. How do we choose one? We will see. The first option is docetaxel, which is a chemotherapy. These are the trials which talked about docetaxel: Stampede, Charted, and GETEG 15. The dose is 75 mg per meter square for 6 to 9 cycles. The benefit is only in high volume patients in the Charted trial, but in all patients in the Stampede trial. When they did a meta-analysis, they found that it is only in high volume. It is not used nowadays for low volume hormone sensitive prostate cancer patients. It is the cheapest alternative available, but so you have to give something more than ADT alone. So you have to give ADT plus something. If your patient has low volume disease, that plus something in today's time is not docetaxel. 2-3 years back, we would still be using ADT plus docetaxel for our patients, but now we do not use docetaxel as the single agent along with ADT for our patients. So what do we use? We have moved on to some tablets, and the most commonly used tablet is abiraterone. Let us have a quick look at the mechanism of action of abiraterone. So this is how the steroid production happens in the adrenal. Now what does abiraterone actually do? So abiraterone reduces testosterone production by the adrenal glands. So testes produce 95% of the testosterone in the body, The remaining 5% comes from the adrenal glands. Abiraterone reduces that 5% production in the adrenal glands. So what does abiraterone do? It actually blocks this enzyme 75 alpha hydroxylase and 1720, not 75, sorry, 17 alpha hydroxylase and 1720 lyase. Now what happens? Because this enzyme is blocked, testosterone production goes down, as you can see, right? All these things on the right side will not be produced, so testosterone production goes down. And because 17 alpha hydroxylase is also blocked, cortisol production also goes down, and that is why abiraterone is always given with prednisolone. That is the concept for adding prednisolone to abiraterone. The side effect with abiraterone is what? Water retention, hypokalemia. That happens why? Because aldosterone goes up. Because when aldosterone is not getting converted to cortisol and testosterone, aldosterone levels go up, and that leads to water retention, hypertension, and hypokalemia. So that is how abiraterone acts. That is why we need to give predni, and this also explains the side effect of abiraterone. Now these are the two trials, Stampede and Latitude. The dose is 1 gram once a day on empty stomach. There are some trials which show that you could use a lower dose like 250 mg or 500 mg if you give the patient a fatty meal, because with fat the absorption of abiraterone is better, so the pharmacokinetics are better. But the standard dose is 1 gram on empty stomach because you cannot control how much fats the patient will take. And you give it with 5 mg predni, you have benefit irrespective of whether you have low volume or high volume disease. The specific side effects are hyperglycemia because you're using predni, water retention, hypokalemia because your aldosterone is going up as we saw in the figure, and you could have some lipid disturbances and LFT derangements because abiraterone is excreted by the liver primarily. Cost is around 10,000 per month. You could also have cheaper options available nowadays. Earlier we used to compare abiraterone versus docetaxel. Let us skip this slide because this is not of relevance in today's world, because we never choose between abiraterone and docetaxel nowadays. The next drug that we have in an armamentarium is enzalutamide, and these are the two trials, Arches and Enzamet. The dose of enzalutamide is 160 mg OD. We sometimes tend to start our patients on 80 mg and then step up to 120 and 160 mg. Some patients in these trials had received both enza plus docetaxel. So what do these trials do? So these, in the control arm was androgen deprivation therapy alone, the injections alone, and the test arm was androgen deprivation therapy plus enzalutamide. Specific side effects. So enzalutamide crosses the blood-brain barrier. So if your patient has a history of cognitive disturbances, or a history of seizure activity, then you would want to avoid enzalutamide. So in very elderly patients, you would probably want to avoid enzalutamide. Fatigue is also a very common complaint that patients come to us with. Enzalutamide is more expensive than abiraterone, but still not very, very expensive. The next drug is apalutamide. This was the trial Titan, in which the standard arm was ADT alone and the test arm was ADT plus apalutamide. The dose is 240 mg once a day. Specific side effects are skin rash. Apalutamide does not cross the blood-brain barrier, so apalutamide does not cause all those cognitive disturbances and seizures. It is more expensive. 25,000 would probably be the least expensive option. It is a little more expensive than that. This is the newest drug, darolutamide. This was the newest trial which has been recently published, the ARA-NOTE trial. Point to note, all the previous trials about abiraterone, enzalutamide and apalutamide all showed OS benefit, overall survival benefit, which is the gold standard endpoint in cancer trials. But in ARA-NOTE, OS was not significantly improved by using darolutamide. Its primary endpoint was RPFS, which is radiographic progression-free survival, which was achieved. So hence it has been approved. The dose is 600 mg twice a day with food. All the other tablets were taken once a day. It has the best adverse effect profile, but it is also the most expensive. It goes to more than 1 lakh a month. So how do we choose? So we choose based on some patient factors, like if the patient has comorbidities, seizure activity history, cognitive disturbances, existing fatigue, and obviously the finances. And this is how the 4 drugs compare with each other. You can probably take a screenshot of this slide and probably have a look at it later. Now we'd usually want to use abiraterone before either enzalutamide by apalutamide or darolutamide, because abiraterone does not work after one of these agents has been used. So we usually try to use abiraterone first unless some patient-related factors preclude its use, so that enzalutamide, darolutamide or apalutamide is kept as a reserve when this patient is eventually going to become CRPC. What are the investigations we do on follow-up? That depends upon what drug we are using. With abiraterone, we would want to check the LFTs and the electrolytes. And if the patient has 5+5 disease, also has a neuroendocrine component, and the PSA is not too high, then if the neuroendocrine component was the majority in the biopsy, we would also consider giving etoposide based chemotherapy to this patient, because that is the chemotherapy regimen for neuroendocrine prostate cancer. Now some meta-analysis have compared these agents. You do not say darolutamide here because it is very new. All the agents are equally efficacious, so there is no clear evidence of superiority of one agent over the others. When we compare dosi with abira, we'll again skip this slide because it's not relevant today. Abira scores over docetaxel. Docetaxel has been given up now, and patients also said that abiraterone is better than docetaxel when it is about their quality of life factors. Now, correct. So that was about the add-on therapy. So we have seen ADT, orchidectomy or the injections or relugolix, and along with that you need to give something which is either abiraterone or enzalutamide or apalutamide or darolutamide for, we are discussing low volume prostate cancer. That is our patient. Now, would you also want to give RT to the prostate, that is treating the primary? So this was evaluated in the Stampede trial, and the rationale is that primary is the seed from where dissemination happens. We do cytoreductive surgeries in other cancers in the body, and encouraging data from smaller series. So that is why it was evaluated in the Stampede trial and it showed benefit. So we are talking about now doing radiation therapy to the prostate in metastatic prostate cancer patients, and in low metastatic burden it has shown benefit. In high metastatic burden patients it has not shown benefit. Our patient is a low volume patient, if you remember. So radiation therapy to the prostate for all low volume patients, the answer is yes. The trials are, there are 3 trials. One is HORAD trial. It only showed progression free survival benefit. OS did not improve. Stampede, OS benefit only for low volume patients. PEACE-1 is the trial which showed PFS benefit but no difference in OS. So finally a lot of meta-analysis has been done. One was recently published just a few months back also, which said that progression-free survival is improved by adding radiation therapy to the prostate in low volume metastatic prostate cancer, but it does not seem to impact overall survival. So what do we do in our clinics? Now, because it does impact progression-free survival, it does provide some symptomatic relief also, we do give radiation therapy to the prostate in our low volume metastatic prostate cancer patients. When is it done? Usually 6 months later, after we've done the ADT and the abiraterone, enzalutamide and all that has settled, the PSA response has been achieved. Because you would want to give radiation therapy only to a patient who's done well with this base of treatment. If somebody has not done well with this base of treatment, there is really no point of doing radiation therapy for that patient. How much do we give? We give 72 gray in 36 fractions. We only irradiate the prostate. We do not irradiate the pelvic nodes, even if they were present at baseline. Can we remove the prostate? We are all surgeons, right? Can we remove the prostate? So we do not have level 1 evidence, but we have a lot of case reports and case series available. And whenever they have been compared to RT, we have seen that the outcomes are similar. I've put a question mark because the level of evidence does not come from a randomized control trial. And you would probably prefer a surgery over RT in a patient who has a very large prostate, is not able to come off the catheter, and has a lot of existing voiding LUTs. So we've done ADT, we've given the add-on additional tablet, we have given radiation therapy to the prostate also. Now our patient only had 3 or 4 meds, right? Because more than that would become high volume. So do you also give radiation therapy to the metastatic sites? Now this evidence for giving radiation therapy to the metastatic sites, which is called MDT, metastasis directed therapy, is only in CRPC and oligorecurrent prostate cancer. Means what? What is oligorecurrent? Which means that you did a prostatectomy for the patient and a few years later the PSA has risen and then you do a PET scan and you see some mets. So this is not a baseline metastatic patient. This is a recurrent metastatic prostate cancer patient, and you're calling it oligorecurrent because the number of mets are less. In this setting, MDT has shown benefit in some phase 2 trials, and the names of those trials are STORM, HORIOL, RADIOSA. In the setting of synchronous metastasis, which is our patient, baseline metastatic prostate cancer patient, There are multiple trials which have been recently reported. They are there in this year's EAU guidelines. They were not there in the last year's guidelines. Extend and transform trials have reported, but they are phase 2 trials. None of them have impacted overall survival. So we think that it does add some benefit, but we are really not sure. So this has really not become standard of care practice. This is something which was published in February 2026. It is called the Wolverine Systematic Review. So they looked at all studies about giving metastasis directed therapy in metastatic prostate cancer. Let us take a minute and read the conclusion. Wolverine showed benefit with MDT for oligometastatic prostate cancer in progression-free survival, radiological progression-free survival, and castration resistance-free survival. But overall survival benefit was not significant, and hence there are some ongoing phase 3 trials which will tell us whether even giving SBRT radiation therapy to those metastatic sites is helpful over and above what we are already doing for our patients. Now we are giving ADT to our patients that impacts bone health, because testosterone is also responsible for maintaining your bones healthy. So it is 10:50. I'll go ahead, or what do we do?
We'll finish this now.
Go ahead.
I'll continue.
Yeah, go ahead. Finish it.
Okay. So regarding bone health, so we give calcium and vitamin D supplements for all our patients. Do we do a DEXA scan? Yes, guidelines recommend that a bone DEXA scan should be done for all patients who are being initiated on long-term hormonal therapy, and these are long-term hormonal therapy patients. DEXA scan is not expensive. It tells you how strong or weak the bones are even before you're starting therapy. So if your bones are not very weak, you would only give your patients calcium and vitamin D supplements. But if your bones are weak, you would want to add the zoledronic acid or the denosumab. We'll just see that. So zoledronic acid is not given as blanket for all patients with metastatic prostate cancer patients. So there are 3 elements in prostate cancer patients which are detrimental to bone health. One is age, because they're all old patients. One is bone mets, because disease is eating up the bones. And this is the third thing which happens because we are giving ADT to our patients, cancer treatment induced bone loss. And along with ADT, when we give prednisolone for our abiraterone patients, we are even worsening the bone health. So ABC is the problem. So we recognize the problem. So we've had this published probably 13 years back, in which they said that in their survey 13 years back, majority of the respondents were not giving guideline recommended supplementation for bone health. Okay. So what do we do is we do the DEXA scan, as I told you. It is routinely available. It is not very expensive. Guidelines say that you should do it. So you should at least discuss it and get it done with our patients. The caveat is that if you have a prostate bone mets are sclerotic bone mets, like unlike RCC bone mets which are lytic. So if you have a sclerotic bone met which is extra dense on the DEXA scan, and you try to measure the activity there, you will probably get a falsely high score. So that is something that you should keep in mind. This is obviously not for you, but for the person who is reporting the DEXA scan. Now, what is the intent? We need to tackle ABC. So in our MHSPC patients, which is our patient, we would want to tackle A and C, because B is not too much, right? He only has 3 or 4 bone mets. That is not going to really impact bone health. So we are tackling A and C, and there is really no evidence for B. In CRPC patients and our high volume patients, we want to tackle A, B and C. And what do? We want to decrease the incidence of skeletal related events, which are pathological bone fractures, spinal cord compression, orthopedic surgical intervention, or palliative RT to the bone. This is what we mean by when we say SRE, skeletal related events. Now, what are the supplements? This is how we give calcium daily, and that is how we give vitamin D daily. So we don't give vitamin D daily. What we give our patients in practice is 1 sachet of 60,000 units to be taken once a week. What about zoledronic acid? It inhibits osteoclast function. So for MHSPC patients, this is what we give: 5 mg by 100 cc infusion once a year. So how did you decide that you have to give zoledronic acid? You did the DEXA scan, otherwise you would not give it. Now if your DEXA scan showed you that there is existing osteoporosis already even before starting ADT, you want to give zoledronic acid to the patient, but not weekly, not monthly, not 6 monthly, once a year. And the dose is not 4 mg, it is 5 mg. For CRPC, the dose is 4 mg given once a month, because there the burden of disease is more and the disease there is not responding to androgen deprivation. There is some evidence to say that every 3 months is not inferior to every month for the CRPC setting. Duration of therapy is not clear, probably give it up to 2 years. A dental checkup is mandatory before you initiate zoledronic acid because it causes osteonecrosis of the jaw. It is a very rare complication but a severe complication, and you would have a 2 to 3 week gap between dental extraction and initiating the therapy. You would check renal function because it is not recommended if the GFR is less than 30, and it can also cause hypocalcemia. Another option is subcute denosumab 60 mg every 6 months. So zoledronic acid once a year. If you want to give denosumab 60 mg subcute injection twice a year, it's a little more, it is quite expensive compared to zoledronic acid. What other advice would I want to give to my patient? That he should do some weight bearing exercises, smoking cessation, and reduce alcohol intake. Okay, so that was about low volume metastatic prostate cancer. Just to revise, we did ADT, we added a tablet, we gave RT to the prostate 6 months later. We thought about doing metastasis directed therapy, but we are not very sure whether we should be doing it or not. And we are working on the patient's bone health. We have done a DEXA scan and we'll decide whether we want to give zoledronic acid or not. Now, that was our low volume patient. We will tackle his catheter also. Now, what if our patient had this on the PET scan, right? You remember the previous PET scan, look at this PET scan. All vertebrae are lighting up, so many bone mets, right? So now this is a high volume metastatic prostate cancer patient. This patient needs more treatment and is probably not going to do as well as the previous patient. So high volume disease, we use doublet or triplet, we'll see, and what are the triplet options. Now, this is our triplet option. ADT plus abiraterone is called doublet. That is what we do for our low volume patients. For our high volume patients, we should do triplet if the patient can tolerate it. And the triplet is ADT plus abiraterone plus docetaxel. It was given to us by the PEACE-1 trial. The trial told us that ADT plus abiraterone plus docetaxel is better than ADT plus docetaxel because those were the arms. It did not tell us whether ADT plus abiraterone plus docetaxel is better than ADT plus abiraterone. So, if you want to ever use docetaxel in a prostate cancer patient, it has to be in combination with abiraterone. It cannot be alone. The benefit was mostly seen in high volume patients, and that is why I'm talking to you about triplet only in high volume patients. And that was the hazard ratio for overall survival. Obviously, we also need to add the toxicity and the cost of three agents. This is the other triplet that we have in an armamentarium. ADT plus darolutamide plus docetaxel. This was the trial. We saw that the dose of darolutamide is 600 mg OD. There it was 600 mg BD. So 1200 mg was used in HSPC setting for the low volume. When it is combined with docetaxel, it is given 600 mg OD. And the specific side effects are that it is, as I told you, darolutamide is much well tolerated, but the cost is a precluding factor. The third thing in our armamentarium for triplet is enzalutamide plus docetaxel. This was the trial, and half the patients had got the triplet, rest got the doublet. So the only thing that changes from low volume to high volume is that you try to give triplet in the form of a chemotherapy agent, which is docetaxel, if the patient can tolerate, and there is no evidence of giving radiation therapy to the prostate in high volume prostate cancer patients. And obviously there is no role of doing metastasis directed therapy when the patient has multiple mets. This is the main difference in how we treat between treating a low volume prostate cancer patient and a high volume prostate cancer patient. Now, some clinical scenarios which we encounter in the clinic. What if your patient, is not coming walking with an ECOG-1 but actually comes on a stretcher with low power in the limbs? Here the concern is whether the loss of power is because of actual neurological deficit or is it just because of bone pain and pain in the legs that he's not able to lift his legs, and duration of symptoms. This is what we want to do. We would immediately want to give a shot of DEXA 10 mg steroids to reduce the cord edema, do an urgent MRI spine, get a neuro or an ortho referral to see if any surgical decompression is required. You would immediately want to initiate androgen deprivation. You cannot give an agonist, so you would want to give an agonist. So even if you do not have a biopsy, If the PSA is high and you have a PET scan, you would give the antagonist injection. We usually tend to not do an orchidectomy unless we have biopsy proof of prostate cancer. And you do guarded prognosis of limb recovery to the patient and the family, because sometimes power can come back if the duration of symptoms is not too long. But if they have come to you after a week of low power, that power may not come back. Now, what about the catheter? Now, do alpha blockers work in these cancerous large prostates? Not sure. Probably not as good as the benign prostates, but we do start alpha blockers in our patients. Is dutasteride required? So would you give silodosin plus dutasteride to your patient, thinking that the dutasteride is going to shrink the prostate over 6 months? The answer is no, because what does dutasteride do? It is a 5-alpha reductase inhibitor. So it inhibits conversion of testosterone to dihydrotestosterone. Now there is no testosterone only in your patient, so there is no question of dihydrotestosterone being produced. So there is no point of adding dutasteride to tamsulosin or silodosin in a patient in whom you are already making the patient castrate with androgen deprivation therapy. When do you give a voiding trial? We usually give the voiding trial about 3 to 4 weeks after we have initiated the androgen deprivation therapy. And channel TRP is something that we do if the patient has failed the voiding trial, and we usually wait for chemotherapy cycles to finish if the patient has high volume disease. What about hematuria? So these prostates can bleed. Does androgen deprivation therapy work? Yes, because it is going to shrink the disease in the prostate. But the next step would be to do a TURP. If that is also not working, you would probably give hemostatic RT, which is radiation therapy to the prostate, or finally do prostatic artery angioembolization. What about pain at metastatic sites? So give palliative RT to the patient. This RT is being given with the intent of reducing pain and not with the intent with which metastasis directed therapy is done. There the intent is improving survival. Here the intent is reducing pain. The dose is 8 to 10 per gray. We can do it at multiple sites, and it takes a few days for the benefit to occur. What about the prognosis, right? So patient and the family have these questions. How long will the patient live? Do I have any clinico-pathological indicators to give an answer to the patient? We usually can predict better when we see the first PSA response at 3 months. So the prognosis depends upon the volume or burden of disease, as you should know the charted criteria, and it also depends upon the PSA response at 3 months. So this is very classical. This is a study about the PSA response at 7 months, and if this is what is happening, based on the levels, you can probably give an estimate to the family about the median survival. This is with ADT monotherapy. Right now you are doing ADT plus some tablet, plus RT to the prostate, plus metastasis directed therapy, plus chemotherapy. The survival is much better than these numbers. So as I said, way back when we used ADT alone, the median OS was about 2 years. By 2016, still with ADT alone, the median OS had improved, because when the patients became CRPC, we had more drugs coming in the market and they were improving the survival. When we started using ADT plus docetaxel in HSPC, the OS shot up to 60 months. And when we started using abiraterone, we had already pushed the envelope to 79 months. Now when we have enzalutamide, apalutamide, and in CRPC we have radium and lutetium and actinium, we are slowly and surely pushing the envelope even further. What about genetic evaluation, right? So do we do it for all metastatic patients? Guidelines say yes. Do we do it in the clinic? The answer is no. We have a discussion with our patients who seem affordable, and then if they do agree, we do a genetic evaluation. We would strongly insist if the patient has a positive family history. What are we looking for in the genetic evaluation? We are looking for mainly BRCA positivity and ATM and PTEN genes mutations, because these are the only actionable mutations that we have as of now. We can prescribe a full 20,000, 30,000 worth NGS for our patient. Does not make any sense, because we only have 2 or 3 genes which are targetable today. Where to get it done? A lot of labs in the city also do it right now, and basic gene testing like BRCA, ATM, PTN can happen in a lot of labs. You do not need to select a big panel. Just a few genes is fine, and the lesser genes you test, the lesser is the cost. Implications for management is something that we will see. Now, what is positive family history? So this was mentioned in the history of the patient also. This is what it is. So this is what you need to ask the patient: a strong family history of prostate cancer, which means either the brother or the father or multiple family members were diagnosed with prostate cancer at an age less than 60 years. Okay, so if he says that हाँ मेरे पिताजी को भी prostate का cancer हुआ था जब वो 80 साल के थे, that is not positive family history. Okay, so if the relatives, close relatives, have also had a diagnosis of an aggressive prostate cancer at an earlier age, that is significant positive family history. Or if you have some other cancers in the family which are not prostate, and if the members were diagnosed at an age of less than 50 years, then it has to ring a bell that this patient probably has a genetic problem induced prostate cancer, and genetic testing should be done. We are going to skip this slide. Okay, so now why do you want to do genetic testing? Because it does have treatment implications. It does have stop looking at the slide, just listen to what I'm saying. It does have treatment implications in the CRPC setting, right? Because we start with ADT plus abiraterone or enzalutamide, and as and when the patient progresses, one option is to use PARP inhibitors, olaparib, okay, PROPEL trial. So when do we use PARP inhibitors? So PARP inhibitors have shown maximum benefit in patients who have BRCA mutation or the HRR mutations, homologous recombinant repair gene mutations. BRCA1, 2, ATM, PTEN are the three main genes. If you have mutations of these genes, then olaparib works. So you would want to know whether your patient has that mutation so that you can offer that drug. Now they say that you should do the genetic testing at baseline, because if you do the genetic testing at CRPC stage, some biological features in the cancer might have changed and the results may not be as accurate. So the tissue at baseline is the best tissue. So do genetic testing at that baseline tissue. And if your patient has the HRR mutation, remember that this patient is a candidate for olaparib or the PARP inhibitors when the patient is going to reach that setting of CRPC. So what can we do something right now for the HSPC setting? This has been presented last year in ASCO, but it has not yet come in paper. I could not find the full paper. It's the Amplitude trial. It's a phase 3 trial, so it's a real proper trial. What are they doing? They're using niraparib. So let's read it. Niraparib and abiraterone for metastatic castration sensitive prostate cancer. So the HSPC setting, so the control arm had ADT plus abiraterone and the test arm had ADT plus abiraterone plus niraparib, so a triplet. Okay, and they found that the benefit was seen in patients, and all patients had only HRR mutations. So a very clean trial, and it finally said that ADT plus ABI plus niraparib is better than ADT plus ABI even in the HSPC setting for patients who have HRR mutation, and that is why for the first time we have an answer as to why should genetic testing be done at baseline for the patient, because something can be done for the patient even at the HSPC setting, not only in the CRPC setting. Now, what if a patient is 90 years old? We can do something called as watchful waiting. Don't do anything if the patient is not symptomatic. You don't do watchful waiting if the patient is symptomatic, but if patient is asymptomatic, you can do watchful waiting, which is what? Don't do anything. Do something when the patient comes back to you with symptoms. Can you do ADT alone? Yes, because even with ADT alone, we are looking at 2, 3, 4 year survival, especially if the patient has low volume disease. And in a very elderly patient, if you are unable to give additional therapies, ADT alone is fair enough. How do we do follow-up? We do it every 3 monthly with blood reports, which includes PSA and a PET scan. What is the trigger for a PET scan? So the PET scan is not done every 3 months. The trigger for a PET scan is any rise in PSA, but a PET scan should also be done once every year, even if the PSA has not gone up. I'll tell you the reason. CRPC, we want to pick up CRPC, right? We want to check whether the patient has gone from the HSPC setting to the CRPC setting. CRPC is defined as biochemical or radiographic progression. So you could have the PSA controlled, but something lighting up in the PET scan occasionally happens in patients, and that is why a yearly PET scan is recommended. And what is the usual time to become CRPC? It actually depends upon how deep the PSA response has been at 3 months. Last 2 slides. So to summarize, Biopsy in metastatic prostate cancer, the answer is yes. But you could do it from a metastatic site also, because the Gleason score does not matter. You would do a PSMA PET scan, and then you would decide whether your patient has low volume or high volume disease. You would counsel the family about the treatment plan and the likely prognosis. You would start androgen deprivation therapy, choose between agonists, antagonists, orchidectomy. We saw how to choose. Add-on therapy, either with abiraterone, enzalutamide, apalutamide, or darolutamide alone with the ADT. If you want to use docetaxel, you can add it as a triplet along with abiraterone or enza or darolutamide for high volume patients. And you would give RT to the primary for your low volume patients. You would give calcium and vitamin D supplements for all patients and encourage physical activity. You would do a DEXA scan for all patients and then decide about zoledronic acid and not give it blanket. You would manage the catheter with alpha blockers. Don't give finasteride, dutasteride. Do a channel TRP if the catheter fee trial is still not successful. Manage pain and hematuria as we saw with those slides. Paraparesis is an emergency. Give DEXA, get an MRI done and decide about cord decompression. And discuss with the patient about generic testing, especially if you have a strong family history, and remember what strong family history means. Thank you.
Thank you, Amandeep. Yes.
Amandeep, every time we hear you, we feel that we have learned a lot. And today, one more important point that you said was about estrogen. I think it was really eye-opener. And
it has very recently come. It will probably change the way we, manage our patients. Probably, I'm not sure, because data for metastatic patients has still not come. But those patients who need 2-year and 3-year hormones for the locally advanced prostate cancer patients, there is an option now, level 1 evidence to use estrogen patches, which are very cheap.
so, if I'm not mistaken, when we were doing in 80s, we didn't have all these drugs. So we were using estrogen only.
Yes, sir. So the thing is, we were using oral estrogen.
Correct.
Oral estrogen causes thromboembolic side effects.
Right.
Patch does not cause thromboembolic side effects.
Yeah.
So we are going back to the concept of using estrogen, just altering the pharmacokinetics to avoid side effects of estrogen.
Fine. No, but it was an excellent presentation. And I'm sure that if we next time we'll ask the students, they will be able to answer all the questions very well. So thank you very much. And we stop here. Correct, Ganesh bhai?
Yes, sir. Thank you, Amandeep.
Thank you so much.
Amandeep, thank you very much.
Thank you.
I know that you are so busy with family and lots of problems. In spite of that, you've taken time to teach. This will go a long way. Thank you very much.
Thank you so much, sir. Thank you. Glad to be a part of this. Thank you so much for inviting. Thank you.
Thank you, Amandeep. Thank you, Ganesh sir, Pankaj sir, Gite sir, Gaurang sir.
Yes, thank you all.
So we stop here today, na?
Yeah,
Yes,
I'll
sir.
stop here.
Yes, sir. Yes.
Yeah.
Thank
Good
you.
night,
Thank you,
everybody.
everybody. Thank you very much.